Good afternoon. I'm Brett Perlman, and welcome to a special Thursday edition of the Center for Houston's Future Leadership Webcast series. We began these weekly webcasts in April, and through these discussions, we've been building a framework on leadership in times of crisis. We have discussed the phases of a crisis, how the framework of adaptive leadership helps us move from response to an unfolding emergency to mitigation and recovery, and then how to use our focus and energy to transition to new ways of working and behaving. Our first three speakers, Angela Blanchard, Judy Lee, and Senator Kirk Watson, helped us to examine the exercise of leadership and the difference between leadership and leadership and adaptive problems. We now turn to public health experts to help us understand the conditions to transition from emergency to recovery and what are the adaptive problems that we know we must change. Today's guest, Dr. Eric Boerwinkle, will share with us the modeling and information that our local leaders are using to make decisions and what that transition looks like. Eric has been on the board of the Greater Houston Health Connect, which the Center for Houston's Future incubated as an organization and whose work we may be discussing today. Thanks to my colleague, former Center CEO Michael Jen, for his help in arranging this webcast. Next week, Dr. Stephen Winder, also of the UT Public Health School, will share how existing health disparities have influenced this crisis and what changes need to be made for a more equitable and healthy future for our community. And now I'd like to introduce our moderator, Russell Richard.
Thanks, Brett. Good afternoon. I'd like to welcome everyone to today's webcast. For those of you who've joined us on previous webcasts, thank you. We appreciate you tuning in. I'm Russell Richard, Vice President of Leadership and Engagement with the Center for Houston's Future. The center was established in the year 2000. This year is our 20th anniversary. The center works to convene business, government, and community stakeholders in fact-based strategic planning and collaborations on issues of the greatest importance for the future of the Houston region. As I've done in previous webcasts, I'd like to recognize our leadership alumni on the webcast today. Thank you so much for your generous support of the center and our work. For those who'd like more information about the center and our leadership forum, please contact me or visit our website, futurehouston.org. Our next leadership forum is scheduled for September 24th of this year. The class is already half full, so please contact me soon for more information about the program and registration. Today is the fourth in a series of webcasts. First, we looked at the timing and the stages of a crisis. Then we examined adaptive leadership and how it applies to this crisis. Last week, we looked at the role of elected officials and how they should lead during a crisis. This week, my guest is Dr. Eric Boerwinkle. Dr. Boerwinkle is Dean of Public Health at UTHealth School of Public Health. He's authored more than 800 scientific papers and led groundbreaking research on the connection between genes and health. He earned a PhD in human genetics from the University of Michigan, Ann Arbor. As Dean, Dr. Boerwinkle manages 6 campuses throughout Texas for UTHealth School of Public Health. Over the last 3 decades, his academic and research home has been Texas Medical Center, which has allowed him to make connections with academic and healthcare institutions. Dr. Boerwinkle and his team have created models for scenarios for COVID-19 case study numbers based on different levels of intervention. Those models have been used by local elected officials to make decisions during this COVID-19 crisis. As in previous webcasts, we will have a Q&A session at the end of the discussion. Please use your Q&A feature in your Zoom app to submit those questions during the conversation. And also, please feel free to chat with others who are on the webcast. Dr. Boerwinkle, thank you so much for joining me today. It's great to have you on the webcast.
Thank you, Richard, for the kind words, and thank you for the invitation. Happy to be here.
Well, thank you so much. Dr. Boerwinkle, I'd like to do the following. I'd like to frame our conversation this way. First, help us understand what is public health and what role does public health schools play in a crisis like this. Second, what is the current status of COVID-19? Third, what role has UT Public Health played in advising our local public officials? Fourth, where do we go from here? How do we move forward as a medical community and a community in general? And lastly, what is COVID-19 teaching us about our public health system? Has it exposed any deficiencies? And if so, what are those deficiencies? So that is the framework for our conversation today. Let's dive in with the first question. And the first question is, what role does the School of Public Health, in particular, UTHealth, play in the COVID-19 crisis?
So thank you again, Richard. Public or population health, first and foremost, focuses on prevention of an illness before it hits. This includes recommendations about lifestyle, early screening for some cancers, for example, and educational campaigns to know the value of your cholesterol or blood pressure, for example, so it can be treated before it's high. In the present context, population health is also continuously surveying and monitoring the health of a population so that we know when a normally quiet infectious disease has flared up in our community, or a rare condition all of a sudden becomes common in a sector of our population. Population health also examines disparities in our community and strategies to reduce those disparities. No doubt the current COVID-catalyzed economic crisis is going to exacerbate health disparities in Houston and its surrounding communities. And this is why, for example, Dr. Shrila Sharma in the School of Public Health is working so hard to build a community health exchange to help coordinate social services, and so that we can simultaneously better utilize valuable donations and make sure those donations have the desired outcome on health improvement. Schools of public health are training the public health workforce and the future public health scientists. In the current COVID-19 pandemic, that means we're training those doing the very important job of contact tracing. We're helping interview each case to find out who they've been in contact with in the recent past. Contact those individuals and ask them about symptoms and recommend testing if appropriate. In this way, we can isolate and slow or even halt the contagion runs before they spread. Considering just the topic of contact tracing, we're very fortunate in Houston and in Texas to have this School of Public Health with its 6 campuses. We have campuses in Houston, Dallas, Austin, San Antonio, Brownsville, and El Paso. It gives us a statewide reach during this difficult time. Finally, public or population health is also a way of thinking. Physicians tend to treat the patient that's sitting in front of them at this moment. We're trying as healthcare strategies that will improve the health of the whole population. Again, thinking about COVID-19, we're working with our local health information exchange called Greater Houston Health Connect, and our hospital and our public health departments partners in the Texas Medical Center and in the surrounding region to identify the predictors of a bad outcome of COVID-19 in our population, and then immediately feeding that information back to the doctors on the front line so they can act to improve those outcomes. So Richard, that gives you a kind of a high level picture of what public health is and what we're doing in the school in this pandemic and beyond.
Well, it definitely sounds like you got your work cut out for you. So thank you so much for everything that you're doing. We really appreciate it. Can you help us understand what are the current COVID-19 numbers here in Houston with respect to infections, death, and recovery? And how do those numbers take into account that percentage of the population who has been deemed asymptomatic and who has not been tested?
So I'll do those separately, and it's going to get progressively a little more complicated.
Okay.
So often these kinds of numbers are at the county level. So I'll talk primarily about the county, but obviously in Harris County, the largest component is the city of Houston.
Okay.
I checked this morning, the number of cases in Harris County is 5,200 plus. So those are confirmed cases. About 1,320 again plus have recovered, and unfortunately, we've had 80 deaths. And my sympathies go to the families, and we're doing everything we can to slow that number down.
Sure.
If we look at Texas as a whole, there have been about 21,000 cases in our state and more than 500 deaths. The second part of your question is complicated. How many people have been infected? The truth is, we simply don't know. No one has carried out the appropriate study in our area to answer the very important question, and this gets us to the topic of testing. And we'll talk about testing, I would guess, more than once during this discussion.
Sure.
Let's step back for a minute and think about testing at a higher level. There's two types of tests, and we need to be clear as we talk about testing. One that uses a method called PCR to examine for the presence of the virus in the nasopharyngeal area, which is a fancy word for way back in your nose.
Okay.
The other examines for the presence of antibodies in your blood that indicates that you've had an infection in the past, but have successfully recovered. Both types of this testing are important, and they provide a different glimpse of the infection in a community or in the workforce. As an active area of, it's an active area of work in our group right now, and discussions today on how would a government official or an employer or a school superintendent, for example, leverage these two types of testing methodologies as part of their plan to reopen.
So, Dr. Boerwinkle, I appreciate you being here today because, myself and our viewers are getting information from a number of different sources. And so we greatly appreciate you giving us the latest information.
Happy to be here again.
When we see reports, however, like the report from TMC earlier today, that suggests that the numbers are not decreasing. In fact, according to this report, we're adding 200 plus cases a day. But then again, we look at a report from the CDC that suggests a downward trajectory. How do we reconcile that information?
It's complicated again. Let me talk a little bit about testing again, because I think testing is important. I think to answer this question, one has to get a little bit technical.
Okay.
So COVID-19 is a condition. It's the condition of having symptoms, where the name of the virus is called SARS-CoV-2. Okay. So when we talk about the number of cases of COVID-19, it's really the number of people who are infected with the virus and who have symptoms. Okay. Some may be mild, some severe, and even life-threatening.
Sure.
When we talk about the number of people infected with the virus, that's the virus SARS-CoV-2. The only way to answer that question is through carefully designed population-based testing, which I'll repeat, really hasn't been done. Okay. And a lot of people ask me about, the peak and when are we going to reach the peak and how we're going to come down from that peak.
Yeah.
And, I have to say, we're no longer modeling the infection, but rather carefully watching the numbers. We're, early in the pandemic, modeling that peak was very important. It was very important for a variety of reasons. Mm-hmm. First, it helped inform our elected officials and business leaders what we could expect under different scenarios, if we did nothing, and scenarios if we only closed bars and restaurants, for example.
Sure. Mm-hmm. Sure.
The modeling of peaks also helped us inform and advise our healthcare organizations. You mentioned TMC a little bit ago, all of the hospitals of TMC, about the expected number of cases of COVID-19 at the peak so that they could plan accordingly and expand bed capacity. And finally, the modeling helped motivate us. It helped motivate our elected officials. It helped motivate the public. It helped motivate the business community about the need for action and to take early action to avoid a crisis in healthcare. So thanks to all of these activities, the people of Houston, the business community have worked together to bend or flatten the curve, and the hospital leaders have expanded their capacity so that the crisis that I just referred to did not happen. And we can begin to have the discussion, and it's an important discussion that we'll have today, on when and how we can reopen and shape this new normal that I know we all look forward to.
Well, let me throw you a curveball here, and I want to kind of stick with this idea of a peak, because a lot of people are asking the question, have we in fact reached a peak? And I'm wondering, is that a good question to ask? And if we haven't, when in fact do we expect to reach a peak? And when we do, does that somehow eliminate the risk of more infections once we reach this peak?
So what happens when we bend this curve down and is that we'll no longer have a peak like the Matterhorn or like the Rocky Mountains. We're going to have more of a hill. And when you're on the top of a hill, it looks a little more flat. And so again, I want to compliment our elected officials, our business leaders, and most importantly, the people who really have worked hard to flatten this curve. And we are now around that peak time. Okay. Like I said, I watch these numbers every day.
Okay.
For Houston, the city of Houston, for Harris County, all of the surrounding counties.
Okay.
To monitor how we're doing day by day. Because as we can talk about is what would we need? What would the steps be to think about reopening? Mm-hmm. And one of them, it's relevant to this question of peak and coming off that peak. Because the virus has an incubation period of about 7 days, and then it also has a little bit more in terms until you may feel ill, we and others are recommending that we have a downward trajectory in the number of cases or the downward trajectory of the number of people testing positive or the proportion of those testing positive over the total, that we have to see that downward trajectory for approximately 14 days. And then we can feel comfortable about reopening. And there are other criteria, by the way, once we, if you want to talk about that.
Sure,
that's
sure.
One of the criteria that links back to this question of when is a peak.
Sure, well, and I appreciate that. And I would like to talk a little bit more about the plan for reopening a little later in our conversation. But for those of us who have been watching the news from the very beginning, we've all witnessed hospitals in different states having shortages of supplies that they need to treat patients. Where do we stand, Houston, that is? Where do our hospitals stand in terms of having what they need today to treat patients with COVID-19?
It's a good question, and it's something I'm sure we all follow. The CEOs of the hospitals and the TMC organizations, as I said, they've worked very hard to help plan and to coordinate in order to ensure the quality of the health care available to all Houstonians during this crisis. I did look yesterday, and it's the last data that I have available is April the 20th, which I believe is Monday, when there were 700, a little more than 707 people hospitalized with COVID-19 in the Texas Medical Center institutions.
Okay.
And another number that we follow very closely, and I follow very closely, is the number of ICU beds total and how many of them are available, because those are the sickest of the sick.
Okay.
And the normal capacity in the Texas Medical Center is about 1,450. The CEOs have worked very hard to create something they call surge capacity, to use places in the hospital that would not normally be intensive care units, to make sure we would have that ability if there was indeed a peak.
That's right.
And we look at how many of them today, and I can tell you as of Monday, most of those ICU beds were empty.
Okay.
More than half of them were empty. So again, that might sound like a disappointment, but it's not. Once again, I think we should be very proud about our people and business leaders working together, our hospitals working together. So we are not seeing the crisis that some other cities are experiencing. However, that's great news, but we need to remain diligent with good public health practices such as hand washing, social distances, while we begin to reopen the economy and get back to work.
Wonderful. No, that is good news. And I commend everyone involved with helping us to control this crisis to the extent that we can. I mentioned earlier this model that you and your team have created that has helped some of our local officials make decisions during this crisis. Can you explain in layman's terms to our viewers, what this model is and how it works?
Sure. So we began to model the spread of COVID-19 in our community with two goals in mind. First, it was to help our elected officials make difficult decisions related to stay home and work safe. My job as a scientist really is to provide information. They have to digest that information, weigh it against many other factors before making those decisions. And we showed that early intervention and an aggressive intervention was necessary to help avoid a potential public health and clinical crisis that we've seen elsewhere. And second, we wanted to provide information to the healthcare leaders about the nature of this pandemic so that they can prepare for a possible surge in infected cases and very seriously ill patients. I want to pause here, though, and underscore something that many of you probably already know. Modeling is just modeling. There's a famous saying in the modeling world that all models are wrong, but some are just less wrong.
Oh, okay.
They're valuable guides, and they're valuable guides for our leaders, but they really don't predict the future. So again, I'm pleased to report that basically based on the modeling, based on the very, brave actions of our elected officials and the business community, the 7 million people in the greater Houston and Harris County area have worked together to bend that curve, and our leaders have increased ICU bed capacity. And I keep emphasizing that because often we don't appreciate when a crisis doesn't happen. But in this particular case, it didn't happen because we took action. And we've avoided what you can sometimes see on the television. But again, we can't let our guard down. So as we begin a phased transition to get Texas back to work, we need to follow good public health practices.
Sure. Well, I appreciate your comments on the modeling because it was just yesterday in the New York Times, there was an article that talked about the different models that were out there. In fact, I think there were maybe 5 or 6 of them. And all of these models had a different, different information. They all showed us at a different level. But your model, I think you've used artificial intelligence in your model. What about artificial intelligence gives you confidence about your model?
Okay. So first, it is the case. My wife likes to joke with me that we used artificial intelligence because we didn't have enough real intelligence.
Okay.
That's a joke. I think it's a joke.
Okay.
It's nothing like your family to humble you.
Yeah, of course.
No, we used artificial intelligence or machine learning methods because they're based on real experience. They're based on what's happened in a similar situation that's come before us. So good news is such models have fewer assumptions and they have many fewer parameters that the values of which we don't know. But you have to train these models on previous experience. So we used several cities in China. We also used Milan and northern Italy. And the bad news is that Milan is not Houston. And so again, all of these models have assumptions. We need to look at them and evaluate them carefully. But nonetheless, they are very good guides as we go forward, because we don't know the future and we're not really predicting the future, but we're trying to anticipate within bounds as we look at our model and others of what could happen, and to help us prepare so we do avoid that crisis that we've talked about.
Sure. Well, so I understand they don't predict the future, but does your model help us understand perhaps where we might be in this crisis a month from now, or 3 months from now, or even 6 months from now?
It can. Again, the time for modeling was early on to help our business leaders and help the elected officials understand the characteristics of that peak.
Okay.
It was also very important for understanding, if we had not done anything, how bad or not, how bad could it get?
Right.
But if we took action, how we could avoid it getting bad. I think that really is the role of modeling.
Sure.
As we look forward, I think the question has changed now. The question is no longer trying to guess when the peak is. The question really is, how do we as a group get ourselves out of this? And modeling, by the way, has a role, but it's a different question now.
Okay. Well, I appreciate that, because we know that the elected officials have been using models in the beginning to make decisions, and we understand that the models are a projection. They're not predicting the future. You're using, I think, more data to drive some of your decisions or drive some of your projections. Can you talk a little bit about the data?
Yeah, the raw data is frankly not that complicated. It's the raw data is simply the counts of cases each day in a particular region. For example, again, early on in this pandemic, we trained our models in several cities in China or from Milan. So we watched very carefully case counts. And then the only real parameter that we began to alter is we had this parameter of when would we intervene and how strong would we intervene. 0 is we would do nothing. And 1 was basically a Wuhan style almost lockdown.
Okay.
And we basically put the parameter at 0.5. That's what we considered when we closed schools, we closed restaurants, we closed bars, we avoided large crowds. We felt, and this is a bit of a guess, that the next step of our current kind of policies within the city and the county, we placed that parameter at 0.8.
Okay.
So we looked at what would happen. And we looked, for example, if we lifted this restriction too early and watched how it could go back up.
Right.
And we looked, for example, how many days did it need to decline before lifting? And that's part of the reason we're recommending, for example, 14 days. And so the model helps us judge our actions and helps us understand what may or may not happen under various scenarios of restricting our population and restricting the economy. But again, I'll repeat, I think that time, there was a time for modeling and it helped guide us.
Okay.
But we're now in a different phase.
Okay.
Where with modeling, we need to understand what it's going to look like as we phase back in to work, and how do we make sure we do this responsibly so we don't see a second peak that could again threaten our healthcare system and bring this crisis back.
Well, speaking of acting responsibly, let's talk a little bit about the reopening of the state, the city, the region. I'm not sure how much involvement you've had in that plan, but can you explain what that plan looks like?
I can only explain what I am advising our elected officials to consider. It will be their responsibility to give us a plan going forward. Once again, my job is to look at this from the eyes of a public health scientist. I'm very fortunate, we are very fortunate here in Houston to bring around us the very best and the brightest minds.
Mhm.
I also have a reputation for bringing together scientists and physician scientists from all of our institutions in the Texas Medical Center. I'm fond of saying that this medical center, it grew under the model of competition, and we're going to grow to be even better under a model of cooperation. So I was honored enough to basically chair or put together and then chair a task force that was going to look at the various aspects of how we use scientific principles and data to reopen the economy and get us back to work. And it had investigators from multiple institutions across the medical center. And I think there are several points that we can bring up. The first and most important is we're going to need to continue our sound public health measures. We cannot let that go down. I think sometimes when people think about reopening and also getting back to work, they think about the old ways, what it was like back in October. We're going to have to think about a new way for a while. So we're going to continue social distancing, continue washing our hands. We will continue to mask in public. We'll have frequent disinfection of our high-touch surfaces. We're going to probably still restrict air travel, which for me is a real difference in my life. I travel a lot, particularly to Washington in my job, and I've never traveled this little in my life. And we will continue extensive contact tracing. Second, we're going to have data-driven milestones before we can reopen. The first of those milestones is having broad availability of rapid and accurate testing. The second of the milestones is data sharing. We need to have the ability to have accurate data, and we're sharing that accurate data between, for example, the state, the county, the city, and coming back to our HIE, the Greater Houston Health Connect. It's important as we build this cohort that we have identity of the cases that are in our communities so we can do the best quality investigation possible to improve healthcare. The third is our healthcare system, or the third milestone is that our healthcare system has adequate surge capacity. We've already talked about that. And the fourth, we've already talked about that 14 days of decline. And finally, our health departments have good contact tracing so we can find the people and end that line of infection. When we put those into place, then we can think about basically lifting these restrictions. However, that being said, we can start planning for this today. We need to plan today of what we're going to actually do at the end of those 14 days. One is, how do we use testing? Again, we're coming back to testing, I think, for the third time. How do we use testing to put us back to work? And what do we recommend? How do we use the finite amount of testing? One is we're recommending that we're going to test all of those people with symptoms, all of them. The second is we're going to test our healthcare workers, our nurses, our nursing home workers, all of our first responders. Third is we're going to have individuals in high contact areas of our economy. Grocery stores, for example. Those individuals who are working in the grocery stores, we're going into the grocery stores. We want to make sure we're not bringing that virus home. So we'll have testing availability. And then again, as we go through contact tracing, we'll have testing. Everybody who we even have a suspicion, we're going to be able to test them. So testing is incredibly important to get us out there. The fourth area is being prepared for the actual reopening itself. What we've done is we've put businesses into categories, and we're creating a toolbox for each of those categories. So our business leaders, particularly our small to medium business leaders, have some guidance of how to do this. We've identified what we call non-essential low-risk businesses, retail, small manufacturing, and low-contact services. They'll be our first area, and they are our first area we're paying attention to and building that toolbox for them. The other is personal care services. I am surprised, maybe as a scientist, I've spent a lot of time having scientific discussions about the importance of barbershops and beauty parlors and massage therapists and gyms, etc. As we come through this. And so that's another area that we need to pay attention to.
Sure.
The third area is we've labeled as our higher risk business of restaurants and entertainment. And so once again, creating for them guidelines in a toolbox so they can have some policies and not really policies, procedures and guidance for how they can reopen their restaurant. The other areas, places of worship and indoor events, will need to continue social distancing. We believe that there's ways that these institutions can come back together, very important for the people in the community, but do it safely. And then finally, is probably one that your audience might feel is a bit unusual, is healthcare itself. As the healthcare industry has worked very hard to tackle this COVID-19, they've also put themselves in dire straits. As they've had to postpone elective procedures, and those elective procedures are how they make their money. So we need to get our healthcare sort of system all the way from primary care to tertiary care to specialized surgeries and get them back into business, or we're putting our own healthcare system into jeopardy. And finally, sometimes if an elective procedure, if you ignore it long enough, it becomes a critical procedure. So we need to get healthcare back.
Yeah, I understand. I understand. Dr. Boerwinkle, it's been interesting listening to scientists make statements about where we are and where they expect us to be, only to have those scientists come back in the evening news and walk back some of those statements for whatever reason. I'm going to put you on the spot.
Please.
Should we expect another wave of COVID-19 in the fall?
Another wave in the fall? Well, first of all, I think even before then, we will have a slight increase. It's inevitable that we're going to have a slight increase. But again, the key to these is remember what we're doing here. We're trying to live with COVID-19 and not overwhelm our healthcare system.
Gotcha.
That's really the goal. And so we need to change the mentality and I think there was initially this early mentality that, quote, we're going to beat this. We're going to make it so there is no more COVID-19. I frankly don't think that's feasible. That COVID-19 is going to be part of our everyday life. We're not yet at the point where we can use words such as, oh, it's going to be the new flu. It's not the new flu.
Okay.
And it's a serious condition in those that are vulnerable. But, there are many people working on a treatment. There are many people working on a vaccine, but we don't have a treatment. We don't have a vaccine yet. So all we can do is, like I said before, collect the data so we can improve healthcare of those patients. And we're working very hard to do that. But the other is we're going to need to change how we live and reopen the economy, go back to school. I didn't mention school a little bit. We're going to go back to school and we're going to learn how to live with this disease. And also, I should say, we're going to learn how to live safely with this disease.
Yeah, this is it's a new day, no doubt.
It's a new day. And the words I'm using is we have a new normal.
A new normal. I've heard that before. How has this COVID-19 crisis impacted our medical health system? Has it exposed any deficiencies, and if so, what are those, and how do we address those?
It's a great question. Actually, if you don't mind, I'm going to expand the question and really talk about this new normal. What has it really taught us about our life? Which includes the medical system. It includes the public health system. It includes our businesses. What has this pandemic taught us? And I'm going to repeat, it's taught us that we're going to live with a new normal.
Gotcha.
And then maybe the most important thing I'll say under this question is there will be a next pandemic. I'll say it again. There will be a next pandemic. And we need to prepare now to protect the public health and protect the economic stability. The public and the business community in general, they understood and they rallied around the current measures that are in place. But as a country and as a region, we were frankly caught flat-footed, and we must never, ever let that happen again.
Sure.
We must establish a scalable public health support service. Think, if you will, about a national guard for our public's health. And so that national guard is in some ways invisible to us until we have a crisis. But when we have that crisis, they are well trained and well equipped and ready to meet that crisis quickly. And I'll call on us to do several things together. Number one, we need to double the public health workforce. And I don't mean just increase it, we need to double it. The second is train and equip that workforce for emergency preparedness. So when there is that next pandemic, all the policies and procedures and training are there. We don't have to have crisis calls to think about where we're going to get, for example, contact tracing. The contact tracers will be trained, will be ready. All we have to do is call on them to do their job. Third, we're going to significantly enhance our surveillance capability so we can see these things coming. Somehow, we relegated pandemic to science fiction and Hollywood. Somehow we thought a pandemic was somewhere in the future. Well, that future is here today. And so we need to be prepared and never be caught flat-footed again. Another point is our universities and private sectors have wonderful laboratories, particularly here in Houston in the Texas Medical Center. We have world-class laboratories. And we need to keep them trained and equipped and ready for surge testing for that next pandemic. Again, thinking about the National Guard. We'll have all the policies and procedures ready so they can turn on a dime as they wind down their regular research and help our medical community, our public health community meet the testing demand very quickly. Next is the hospitals, and they're well prepared now with their surge plans, but we need to have those surge plans always in tune and drill them. Again, just like the National Guard, I hate to kind of abuse this analogy, but basically have them do periodic simulations and drills because there will be that next pandemic and we need to be ready for it.
Well, thank you, Dr. Boerwinkle. This has been a great discussion. I want to use the remaining time to take some questions from our audience. First question for you is, when someone with COVID-19 dies, does the virus die with them? Is there any risk to anyone exposed to those bodies immediately thereafter being infected?
So it's there's several layers to the question. That just being in the presence of a person who's passed away from COVID-19 is very little risk because the virus is spread usually in the form of droplets of liquid, droplets of excretions from ourselves, for example, a cough. And I don't want to be too morbid, but that's just not feasible when a person passes. On the other hand, one can have the virus on a surface. A skin is a surface. The surface of a home of someone who's passed. So these areas do need to decontaminate. Also, our funeral and mourning industry has had to respond to this infection, but there are policies and procedures already in place for that industry to deal with a person who's passed from an infectious agent like this. Particularly in some of our smaller communities, I've heard that the funeral industry is overwhelmed. They're not used to having a cluster of deaths, so we have to keep that in mind.
I can imagine. I can imagine. Dr. Boerwinkle, a few more questions for you. Can you comment on the different types of antibody testing and which are accurate in your opinion?
Yeah, so again, let's go back and remind particularly of those who may have joined late. There's two types of testing. One is testing for the presence of a virus, usually using a method called PCR that just tells you whether there's an active infection. The other is antibodies in the blood. And again, there are different types of tests looking for those antibodies. First of all, there's different kinds of antibodies. Again, it's going to get technical that the first ones to turn on is something called IgM, and then there's IgG and IgA. It's like scientists have invented the alphabet all over again. and those measures, they mean different things to the investigator. And usually, for example, IgA is something it's going to come up in a sputum, where IgG and IgM are in the blood. I think the important part, though, I think not so much the technical part of this for everyone to realize is we don't yet know whether the presence of these antibodies protects us to a great degree from the next infection. And that's something we are going to learn. We're going to learn from experience. We know about case studies where people have had antibodies, but yet they did get infected. So we know it's possible, but we don't know the degree it's possible. And that really shouldn't scare you. I'm sure everyone on the audience has had the experience. They've gotten their flu shot, but I'll be doggone if they didn't get the flu.
Yeah, I'm one of those.
Okay. And so, we know it happens. So I don't think you're not totally immune. You enjoy a degree of protection. And in this case, we just don't know the degree of protection yet for people that have those antibodies, nor, and importantly, do we know how long the antibodies basically will last. We hope they would last, for example, for a year. And that way, once there is a vaccine, we can have an annual vaccine like we do the flu. But again, we just don't know. There's a lot we don't know.
I understand. Yeah, this is something new, and we're learning as we go, I suppose. Dr. Boerwinkle, you mentioned earlier, certain criteria that we need to meet moving forward to reopen the city and so on and so forth. And you mentioned 14 days. Where do we stand in this 14-day window?
Yeah, again, I usually focus on the county just because we are a mobile group. In fact, I focus on the surrounding counties. Unfortunately, we had a peak 3 or 4 days ago. We were coming down and we had a peak, and now we're coming down again. So I would say we're 4 or 5 days into our 14 days. But like I said, I watch this very careful. If you look at the city of Houston itself, it actually is well along. And so that peak that I just referred to was actually outside of the city. And we're seeing that even though for a while, the sort of hotspot, it's a bit of an abused word, but the hotspot tended to be in the city. But now we're seeing that the hotspot is in our surrounding counties. But again, I think because we're so mobile in our society and we work. So when we go back to work, as many of you know, because you fight the traffic every morning and evening, people need to go, in and out to go to work. And so I really think it's important for our city and county leaders to be in lockstep about this opening. I don't think it would be a good idea if one county decided to open and another county didn't, or Houston decided to do one thing and Harris County did another. Sure. I'm very pleased to see that in our mayor and our county judges have been communicating and working very careful and sending a very consistent message. Sure. And I hope that continues as we work together to reopen and get us back to work.
Oh, I agree. I think that has to happen. Next question, Dr. Boerwinkle. Can you talk to the strategy, if there is a strategy, to address pre-existing or emerging mental health issues that are connected to this pandemic?
Texas historically has not been a major supporter of behavioral and mental health needs. But over the last several years, thanks to the wisdom of the Texas legislature, we've come a long way in addressing the mental health needs. We're not certainly there yet where we want to be, but we've come a long way. I do think it's important. I'm going to focus on the new emerging behavioral and mental health needs. We are going to need to be very sensitive that the current stay home has created behavioral health issues. We're going to need to look for peaks of substance abuse, alcoholism. In the newspaper, there have been reports of increases in domestic violence. When we do get back to work, our employers are going to need to watch for the signs of those emotional issues in our workforce. I think importantly, in the fall, as our students go back to school, our teachers and nurses are going to need to be alert, not just of the temperature of their forehead, but the health of their emotions.
Sure.
And we need to put together a support structure in our communities and across the state to help meet those emotional needs and be creative about it. Some of our traditional methods of one-on-one counseling will likely need to expand because of the large numbers, where it will have creative solutions to these behavioral and mental health needs that are going to be needed. And I'm quite hopeful will emerge because of this sort of new cooperation and resources in the behavioral and mental health community that is now present in Texas, that we need to now put that to work and continue to grow it and strengthen it going forward.
Dr. Boerwinkle, I really appreciate your time today. We want to be respectful to your time and your schedule. I'm certain that our viewers have many more questions that they'd love to ask, but we just simply don't have the time. How might they get answers to some of their questions?
Well, the internet is, first of all, both the county health department and the city and the state health departments are good sources of information. Our Harris County has a wonderful portal viewer that I would send them to, the Harris County Department of Public Health. That's often a place that I look to get counts very quickly and pictures. Be very aware of sort of the political tensions and false news that is coming out. I would go to trusted news sources that are based on science and information. That would be my first piece of advice. And the other is, I'm busy, but I pride myself in being accessible. I'm here to serve. I'm a state employee. I'm here to serve. And so my email is eric.boerwinkle, just the way it's spelled in the announcement for this, at uth.tmc.edu. So feel free to email me a question. Don't be disappointed if you don't get a rapid response, but I will respond to as many as I can. And back, Richard, to your kind comments. Russell, I'm sorry that, I was very happy to be here, and I hope the information was helpful.
This has been wonderful. Thank you so much for being so generous of your time. I want to thank our viewers for being with us today. Please be on the lookout for information on our webcast next week. I'm Russell Richard. Good day, stay safe, and be well.